So what is the number one leading edge tool we can use in modern non-surgical orthopedic medicine? I'm Dr. Tait. I'm a non-surgical orthopedic doc, regenerative medicine doctor, and that's what I'm jumping into today because almost all the patients that seek me out are not looking for surgery. They have maybe seen a surgeon and they've been given some options to think about or maybe a recommendation to get surgery. And of course, they want to come to somebody who doesn't do surgery and say, is that my only out? Is that the only option? Do I actually need surgery? And that really is my job. That's my duty to my patients, to really look at the details of their case and give them that clarity on the path. Because there's absolutely injuries that walk into my practice daily that need surgery, right? People don't want it. Everybody has the common party line that it's the last resort, and I think it would be for surgeons themselves. And I've been fortunate to treat some colleagues over the years with my tools, and look, they're trying to avoid surgery too, but where's the time and place that you need surgery? And a lot of that comes down to what we're focused on is reestablishing the integrity of the joint, whether it's a knee or shoulder. Today I'm talking a lot about shoulder injuries, because what we don't want to do is ignore something that could have been surgically treated, and now fast forward 10, 20 years, somebody's got an arthritic shoulder. They're in their 40s or 50s, and now they need a shoulder replacement. It's a bad situation to be in. So again, sometimes our own internal bias to steer us away from surgery, even though that's the best thing to do, could compromise the future of your shoulder. So let's dig into the things that I do. So in another video, I went through the anatomy of the shoulder, really got in depth about rotator cuff injuries. So if you didn't see that, go find it here on the channel. And I walk through all the types of rotator cuff injuries because that's the number one thing I see in my practice that walks in. The secondary thing I see in my practice is if we could strip these muscles away from this model here and look underneath it, we could see the ball and socket joint. There's also another joint here on top of the shoulder, this AC joint between the collarbone and the shoulder blade. And those two joints can become arthritic. That could be due to prior injuries. If somebody was a subluxer or dislocator, they could have beat up the joint some doing that. If they jam their shoulder into people for a living or just for fun, back in the day playing football, hockey, rugby, whatever it is, or just heavy benching, right? Like a lot of guys like to do, load up those plates and just rack it out. I mean, that can wreak havoc on this joint. So, when we get around this and we see somebody, like I always talk about, we need supreme clarity on what is the actual injury. And we got to get there by way of some type of imaging, whether it's x-rays, MRI, musculoskeletal ultrasound, like the thing over my shoulder here I use commonly in my practice to look at people dynamically in my exams to really understand what they have there. Because then if we get into the what, so say this isn't a category that, hey, you do not have a full thickness rotator cuff tear. Great for you. You do not have end stage shoulder arthritis where you can barely lift your shoulder anymore or rotate it or loop a belt behind your back. When people start to get really compromised range of motion because of the shoulder joint, because of arthritis, it's a really tough situation. And I'm just being honest, for me to change as a non-surgeon, I can take the pain level down by multiple tools I use in my practice. When we start to lose range of motion, that is a big problem, and we would ideally want to catch that patient before we end up there. So again, if this is slowly going downhill for you, if you're losing motion in this shoulder, it's becoming more restricted. Your ability to get your arm up overhead or behind your back is becoming more restricted. Man, that is the time to act. Do not wait on that. Because again, if we lose that motion, sometimes it is very hard to give it back to people if it's related to arthritis in the shoulder. Now, if the capsule of your shoulder tightens up and you get something called a frozen shoulder, where the capsule tightens up and restricts your motion, well, there's a lot of great treatments we can do for that. And we can usually pull people out of that situation, get their range of motion back. But if it's arthritis, we don't want to mess around. Time is tissue. And I tell people, man, if this has been a pattern for you, and hey, if you're a guy, it's probably been a pattern for 5, 10 years, right? You just ignore it. But if this motion is going down, 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 and we know that's an arthritic component in the shoulder, man, we got to act there. So what are the things we act with as a non-surgeon? The treatments that are in my toolbox, of course, are mechanical rehabilitation, right? If somebody's in pain, they're starting to hike their shoulder, they're dropping it, it's internally rotated, it's kind of this protection posture. So the first order of business is, how do we open this shoulder up and get people back to what we call a normal range of motion functionality with that shoulder, where their shoulder blade and the shoulder, all the muscles around the shoulder are working in harmony, and ideally with good range of motion. That's where I involve my physical therapy colleagues or good personal trainers, strength coaches, people that can really teach good fundamental movement mechanisms to get that shoulder back in alignment. Then we can work on, can we strengthen this thing up enough to get to a point where people are happy? However, if we have these tissues injured, if we have rotator cuff tears, partial tears in particular, I'm going to talk about both today, partial and full thickness, we need to get in there and do some type of treatment, because oftentimes those are not rehabable, meaning people will always have a limit there. They might be able to get their motion back, they might be able to build some strength back, but man, as they really try to push it hard dynamically back into sport, almost always they're going to foul. There'll be a foul point there, and it's because the tissue. Look, if this is supposed to be an integral system of muscles, and we have a tear through part of this, it's just not going to function the way it's supposed to. And if we've given it enough time and space, 6 to 8 weeks, or even 6 to 8 weeks over and over again, and we've done some good rehab and it hasn't healed, the number one tool I use in my practice now are things that can stimulate healing. And the most common tools we use in shoulder injuries, whether it's rotator cuff injuries, AC joint, glenohumeral joint arthritis, labral injuries, it's platelet or stem cell therapy. And what are these things? Platelets are derived from your bloodstream. So if we take a blood draw and we separate red and white cells, we get platelets. Platelets have growth factors. Growth factors stimulate healing. Same for stem cells. We can take stem cells out of fat tissue in your body. We can take stem cells out of bone marrow in your body. Neither one of them is a tough procedure, but the beauty of this is your body's innately designed to repair itself. A million cells a second turning over, a million cells replacing them. So again, time and space doesn't heal. Rehab doesn't heal. Next step, we want to start thinking about what types of things can we inject that can stimulate healing. So almost always in my practice, then we're going to lean into those type of treatments. If somebody's worked through those steps and failed, they haven't been able to get their shoulder back to the level they need it, now we got to stimulate that thing to heal. And again, there's a lot of nuances with why do we use platelets, why do we use stem cells, but think about it as magnitudes of power. You know, platelets are pretty powerful, stem cells are more powerful, combining the two is the most powerful. So that gets us around 3 other factors, okay? What's the extent of the tissue damage? How old are you, the patient, and how long has this problem been here? So those 3 factors are going to help us determine what's needed there to stimulate the amount of healing we need to get that tissue to heal. So let's get deeper in the details there and talk about partial tears versus full thickness tears. Okay, so if we have a partial tear of this tendon, it means we have a small tear. As I've detailed in other videos, there's a depth of tear and there's a width of tear when we talk about these tendons in the shoulder. So the smaller tears, of course, you would think are going to do better, and they almost always do because it's a smaller tear. So we can stimulate healing into that thing. We can have some fibrous scar tissue come back together, fill in that hole, and now it's just a stronger tendon. Now know this, there's no way if you have a tear to actually reconstruct the fibers of that tendon across that tear. So what we think is happening and what we're getting there is what we call granulation tissue, fibrous tissue, scar tissue, but it does fill in that gap. So now instead of a cut through the tissue here, a tear through that tissue, it bridges that gap. So you have more structural support. Like if there's a hole in the wall over here and I fill it, it's going to be stronger. Now if we have a full thickness tear, so again back to the Dr. Tait hand model I like to use, okay, if it's full thickness, okay, that means the fibers have torn completely from the top to the bottom. If it's full width, if we flip it the other way, okay, full width means we've torn it front to back. So that's what we call a complete tear. Through the full thickness, through the full width. Now, we're typically talking about one tendon, and there's a tendon in front of it and there's a tendon behind it. So now, back to the trusty Dr. Tait hand model, if these were the tendons and I tore this tendon, okay, there's still tendons intact in front and back, but we have this hole in the middle. So that hole can be infilled with tissue. So if somebody elects not to get a surgery, say they just are adamantly opposed to surgery, or they're at an age where they say, or are told, hey, if you get surgery, there's a high percentage chance of re-tearing, which there is for older patients, even with the best surgeon surgically repairing that thing, and somebody decides, I don't want to do that. Well, there's some good data and anecdotal, also in the literature, in my practice, experiential, that if we take fat, what we call microfat, we can take fat and we can kind of beat it up and micronize it down, and all that means is I can inject it. And we can use it as a filler. We can infill that gap in there, we can seed it with platelets or stem cells, and we can stimulate some relative healing of the remaining tissue around that tear, and we've filled that hole in the middle, so by creating better strength across that whole rotator cuff, front to back. So it's an interesting treatment that we've used quite a bit with people that are either not great surgical candidates, maybe medically they can't have surgery, or at age, again, they're told, hey, there's a high percentage chance this thing's gonna fail, or sometimes the patient also has pretty significant arthritis in the shoulder, and so they may not want to elect to treat the rotator cuff, and instead they're given a position of, why don't you do a replacement of the shoulder? And a lot of patients maybe don't want to go there. If it's a pain factor and they have good range of motion, oftentimes we can help that pain with that type of procedure. When we get into articular cartilage, so this is where we're talking about, what is the cartilage on the end of the bones, either in the AC joint or the ball and socket joint of the shoulder, and that cartilage is kind of eroding down through different stages of change. This is where we're typically going to use a stem cell. And this is where we can take it out of somebody's bone marrow, the pelvic bone, the ilium bone, in particular is the most common harvest site. And so we can get these stem cells, we can get platelets from the arm, we can use those powerful growth factors together to put it in that environment for two purposes. One, it's going to shut off inflammation and pain through a different mechanism than something like a steroid shot. And then the other part of this is we want to see, are we able to slow down that aging of change? And that's what we're seeing. We think we're potentiating the longevity of one's joint. Again, as somebody goes through life and they're aging, and we want to get people to a high level function, back to playing sports and training, doing the things they love doing. So you think about it, as you age, as you're using this thing a lot, if we're able to turn the situation around and you have a great shoulder, it's not painful, you're able to get back to those things, but you continue to be an active person, which I want you to be, and you're going to continue to age, which I don't want you to, but you're going to. We put those two things together, most likely you're going to have a re-injury of the shoulder, or if we were able to tip it back for a while over time, maybe a few years later, 3, 4, 5 years down the road, and I have patients that are 7 years plus out that are still doing really well from a pain reduction and functionality. And that really is the key. I mean, if you're out there living with shoulder pain, it's about pain and it's about function. Can we take your pain level down to a level that allows you to get back to the things that you need to do and love doing? Can we bring the functionality up where you can do what you need to do, right? Whether it's everyday stuff or being an active person. And if we can do that with these modern tools in non-surgical orthopedics and get you back to where you want to be, and the potential flip of that, if we don't do the thing, right, and your shoulder continues to dwindle down the hill, then it almost guarantees that you get into a surgical bucket at some point. So, what I always talk to people about is the time machine. We can't take the time machine back. A lot of people end up here with a really bad shoulder. It's restricted in their range of motion. And I hear things like, man, I wish I could have went back 5 years and known this now, because I would have done it. So now you know it. You know the options that are out there in non-surgical orthopedics. And your job now is to find somebody, hey, if you don't live right here in Tucson or the Southwest where I practice, find somebody that's really qualified to do this, that you can get a really good opinion from, that they can dig into the specifics of your case, give you all the options, both surgical side, non-surgical side, so you can make a great choice about what to do with your shoulder so that you can pain less, hopefully live a lot more with the shoulder you have, and avoid surgery if possible. So if you like that content, hey, click the like button. If you want to see more content like this show up and want to know when we drop new content, to get notifications, subscribe to the channel. And if there's anything you want to understand at a deeper level about any of these modern tools that I'm using in my practice as a non-surgical orthopedic doc, please drop them in the comments below. That tells me what you want to learn, what future content I should create around this, so that you can just have a really deep understanding of everything available to you or the ones in your circle that you care about. And speaking of that, if you have an issue that I can help you take care of, in the notes here below the video, you'll see a link takes you over to a form on my website, and it's very simple, few questions. It gives us some perspective on what you're dealing with, and some smiling, happy team member on my team is responsible for looking at those daily and reaching out to the people to see if there's any way we can help you, whether you're here in town in Tucson or the Southwest or anywhere else in the U.S. for that matter. We at least give you some direction on your case. So hope you enjoyed that, and we'll see you on a future video.